Good morning and welcome back again, once again from Mount Sinai, live from here in New York City. I'm joined by one of our esteemed colleagues, Dr. Chris Metzger from Ballad Health in Kingsport, Tennessee. As always, Dr. Karthik Gujra, one of our partners here as well. Very glad to have you. Thank you for joining
Honored to
us
be
today,
here.
live, in person, no more Zoom. All right. We have a really fantastic case today, led by our very own Dr. Prakash Krishnan, who's back from gallivanting around the world, celebrating life,
Pepper.
and Dr. Vishal Kapoor.
Good.
So without that,
8,000.
any further ado, let's pass it on to you guys inside. What do we got today?
Well, welcome again. It's a great thrill today for us to have Dr. Metzger here in the lab. I mean, it's part of our ongoing series of having guest moderators who can really assist us, advise us, also more importantly add their expertise to your learning, which is incredible. And so I think this is part of what's a real thrill for us to have someone like Dr. Metzger. I mean, I just want to go on a little bit about my dear friend. I mean, I've known Chris close to 20 years or a little less than that now, and had the opportunity to watch him both perform live cases at our NY what is it called? NYEBS. I'm sorry, I'm just hearing things. Guys, let me know what you're doing.
Nothing,
These
just
things are all
flush.
attached. Okay.
Got it. We are here to give you stuff.
Yeah, so and it's just a thrill to have him actually come here all the way from Tennessee. Kingsport is obviously not a nonstop flight. I don't think. Chris can correct me, but I don't believe it is. So therefore, it's an incredible effort that he actually is actually here. I do want to ask one thing is that our audience that's always joins us to please send us questions with about this case, and let's discuss all the nuances that go into a case such as this. So without further ado, and thanks to Chris for making the trip, I want to introduce to my right my colleague, Dr. Vishal Kapoor, who's the director of Mount Sinai Morningside, which is on the west side here, and I really appreciate him being here. He's always here for our cases. We've got to my left, Ray Lascano, our interventional nurse practitioner, and to Vishal's right, we've got Osman Jaffa, one of our two endo fellows this year. And also for those of you who are looking for fellowships, Chris Metzger also has fellowship. So it's one of the few, me and Chris and a few others like Kenny run throughout the country. So it's actually a great opportunity to learn how to do these very difficult cases. Our nurse in the room, again, very strict and very, how can you say, patient-oriented is Elizabeth Holton, and then Damien Cabrera is our extraordinary technician. So without further ado, since we're going to try to get this done in exactly an hour, we've got, Osman is going to present this case to Dr. Metzger and all of you. Osman?
Hey, thank you.
Okay, weekly.
He's coming, right?
Yeah,
So
please.
this is a 66-year-old male. He has a
Time for ACT?
history of Takayasu's arteritis, PAD with a right common iliac stenting in 2014, bilateral common end arterectomies that were done in 2001 at outside hospital, occluded left carotid, left subclavian bypass, chronically occluded left subclavian artery, multiple PCIs since 2013, followed by a 3-vessel bypass January 13th of 21 with a RIMA to LAD, SVG to RPDA, and SVG to Ramus. He presented with CCS Class 3 angina. PCI was done to the mid-RCA in the setting of occluded SVG to RPDA in February. At that time, it was a right radial approach, and there was a gradient of 30 found across the ostium of the right subclavian artery. His angina persists despite PCI of the RCA, and he presents today for intervention of the right subclavian artery due to ischemic symptoms that are persistent despite his medications, as below. He's on Aspirin, Brilinta, Repatha, Crestor, Imuran, which he's been on for some time now, Metoprolol and Diltiazem. BP is 110/80. His labs, creatinine, hemoglobin, hematocrit are normal. LDL is 22, and ESR and CRP are within normal limits. He'd recently seen rheumatology with the clearance from them
Probably because of the Imuran.
just in the past couple of months.
Repatha.
This is his CT. He's got complete occlusion of the left cervical internal carotid with partial opacification of the intracranial segments with reconstitution in the middle cerebral. This is unchanged from prior CTs, really going all the way back to 2013. Also, occlusion of the left subclavian to the level of the vertebral where there's reconstitution, and moderate to severe stenosis at the origin of the right subclavian artery. The measurements that we did of the innomina is about 1.7 centimeters, and the right subclavian at the proximal portion is 1.2 centimeters. This is his cath. You can see there's significant stenosis in the mid-RCA. His left main is occluded, and this is a non-selective shot of his RIMA going down to the LAD. This was done back in February. And over here we have his aortic root shot with the type 2 aortic arch, significant tortuosity, you can already tell. Selective shot of the right subclavian, and then we pulled back here a little bit, and you can see that extreme tortuosity with the challenging takeoff of the RIMA right there, right at the portion where that stenosis is. This is his carotid duplex. Right-sided velocity is really within normal limits. Left side, however, you can see an occluded bypass, left internal carotid really with no flow there, and left vertebral retrograde flow consistent with subclavian steel in that area. That will go on with the.
Yeah. So I'm just curious, what do you guys are thinking about? Don't move, sir. What do you guys are thinking about our case? So I just want to tell you what we've done here, Chris, and Karthik. We've crossed with a vertip catheter. I don't know if you guys were able to see it, but now we're going to go ahead and drag our catheter in. But at this time, I'm going to have them take this. But Chris, I just want to go over a little bit of plan where we check our ACT. You know, let me hear what you think and what Dr. Gupta as well as Dr. Sharma think. You know, Dr. Kapoor and I had some ideas, but obviously when we have you, we want to know what your thoughts are on such a difficult case. You saw in the angiogram, the RIMA is involved. It's to a dominant, it's an LAD, so it's obviously a big deal. There's a dominant vert, you know, the contralateral subclavian is occluded. So we need to get better imaging here with IVUS, but I just wanted to get your thoughts right now while we get things ready.
Great. Well, PK, first of all, thanks for the invitation to be here. And so for all the people that were wondering and waiting on the edge of their seat, there is no direct flight from Kingsport to New York City. So for all that, I'll just throw that out there. It was a two-flight affair. It is great to be here with friends where all the magic happens and to watch you work. So PK, this is a great case. You know, there's a lot for us to talk about. It's a short segment that we're going to work on, but that segment is critically important. Yeah. It is right after the common carotid artery, which is important, obviously, but it also the left carotid is out. Right. It's right before the right vertebral artery, and the left vertebral is filling retrograde and non-dominant, and it's proximal to the RIMA, which is his LAD. So it's short, but it's usually a big artery. I think you said 1.2, so that's even bigger than most right subclavians. So we're going to have to think about what strategy we're going to use for a short segment, large caliber vessel we cannot embolize, and we've got to keep it there. So the access, you have bilateral access, PK, is that correct?
I've got, you know, one of our favorites, you and I love this brachial access. The radial obviously has been used multiple times, is not usable right now. I've got, get a 2E please, and I've got an 8 French, and I went with an 8 because we had equipment issues. We probably would have gone with a 7. So I went with an 8 French in the groin at this stage, just to have plenty of availability to be able to shoot around and image while we place our stent, if that's what we decide to do. So that's our access points. We have a 5.6 slender on the other one, Chris.
So I will say that maybe a fortuitous, maybe your supply chain person is a genius that didn't have your 7 French. I like an 8 French anyhow, because now if you use a larger device, you can inject dye around it, visualize it safely, because you don't want any air getting to the brain or the right vertebral artery.
Exactly.
So I think supply chain person was a genius, and they were trying to help you, PK, is what I think.
I agree, Chris, because, you know, at this stage, it's, you know, when we're working in such a area where, you know, obviously no air, error is unforgivable. This is definitely, I agree with you.
So let me ask a question. This is Takayasu's. I'm assuming it's burnout Takayasu's. Yep. At this point, he's had a lot of procedures done. Is there anything you do, PK, to check the activity level, or your rheumatology says just go ahead and do this?
Well, you know, we did a CRP. We also did a ESR. No, we did both. We did both, and
with the normal limits.
Okay.
Yeah.
The only thing though is that it's, you know, for a patient who's undergone CABG in the setting of known Takayasu's, you know, typically the LAD is always revascularized via the LIMA. So there's known disease from the left subclavian, which is why they chose the RIMA.
Ready?
I wonder if on the location and the kind of the non-diffuse nature of this almost makes it seem as if the right disease is actually not from Takayasu, because it's such a short segment. Was there like that typical halo sign that we see on the transverse of the subclavian on the right from the duplex? Osman, I don't know if you got to see those images, did you?
Did you see the images, Osman?
Yeah, those are the main ones I have there, Raman, that I went through. Did not see what you're mentioning.
Right.
Yeah.
Okay. So PK, take us through so you've got a, what kind of wire? You've got an 035 wire from the shuttle sheath into the brachial artery. Is that correct?
That is. And I want to take a picture now, Chris.
Yes, please.
We're just making sure that our ACT is good and everything is good before we do all this. Because as you know, we did have, no clots are allowed as well as air. So right now we got an initial ACT. We're doing it on heparin because we're in the subclavian with all this going on. If in case we have to reverse or something, normally we would do it on max like our coronaries, but at this stage we're doing it on heparin. So now I'm just checking a second ACT. I know it's overkill. But we're checking a second ACT and making sure that we are therapeutic. But in the meantime, obviously we're hooked up to pressure. Flush forward, please. We're hooked up to pressure, and therefore we will be able to take a good picture. Our waveform is good, so I'm confident we don't have any sort of air prep up, please. And I'm just going to inject. It's a non-selective injection of the subclavian, but I think you should be able to see it before I drag my sheet. I'm going to have Vishal, after taking the picture, put a guide catheter over a wire near the subclavian so we have bilateral gradients before we go ahead and start. So here's a picture, sir. So the view for everybody with the right subclavian is probably the best view is an RAO 20, caudal 20. It really gives you a nice layout of the subclavian. I'm just going to mag up a little bit to give us a little bit more of a view. Right, so we're just going to go, that's just in the arm.
It's at 30 gradient.
Sir, just take a deep breath in. Hold your breath, hold your breath, hold your breath. Don't breathe, don't breathe. Little picture right now. Yeah, one more. We're going to do one more. Breathe normally for a second.
So while he's loading this up, those are the views. There's two views, I think, for the here. Yeah. The Barbara Walter 2020 view, as you mentioned there, displays out the common carotid and the subclavian bifurcation. And then the other view is the contralateral cranial that gives you the origin of the vert often. So, for the origin of the vert, if you need that for placement of a distal end of a stent, for example, then contralateral cranial is the way to lay out the vert. Now, you were seeing a lot of washout. Let's see. Let's watch that. There we go.
You can see right there. There's the lesion. So there's, like I said, a 40 millimeter gradient with anterior ischemia right now. So Vishal, can you go up with the wire while we just talk here? So Chris, it looks like we have a little stump there for the ostium of the subclavian. We're obviously going to image it with IVUS before we do anything. And I just wanted to get your thoughts on what are the things you're looking for in terms of the RIMA. Would you protect it? Would you not protect it? In this view, you can see the RIMA has some ostial disease, Chris. And one of the things we thought about is with our our coronary experience, as you and I know, bifurcation, ostial disease. Then do you protect that side branch with a wire, or do you balloon it? Here, I'm not wanting to balloon it, but definitely protecting it may not be a bad idea, and that's what I was going to ask you as we go up with the guide here.
Yeah, so a couple questions. I like the heparin and everything there. I'd get the wire as deep as you can in the arm. And then I might even think about taking your shuttle sheath into the very proximal subclavian.
Absolutely.
It'll get you a better view. Now, in terms of protection, I'm going to get my panelists. I'll give you my thoughts and then get to the audience. I think we can be, if we're not careful, protecting in these cases can actually be unprotecting, put us at risk. If you leave a wire, let's start with the vert. If that wire migrates into any branch of the basilar artery or pike or anything like that while you're doing a complicated case like this, then you're going to really regret having a protection wire. I think the embolization rate during subclavian interventions is pretty low. And the RIMA and the right vert are prone to spasm. And so leaving protection systems in there or even wires is not necessary. The other nice thing, PK, you've got bilateral access. So you have easy access to either the
use the
RIMA
regular stuff.
or
Or
the
the
right
vertebral.
vert
Yeah.
from the arm.
Yeah.
And so you can
Exactly.
do whatever you need to do. So I personally, what do you guys think? Would you put a wire in either of the vessels?
I think given the oscillations of the RIMA, I think I would have a really hard time, despite all the very accurate points you're pointing out. I have a really tough time convincing myself not to. At least with just a wire.
Yeah.
You know.
Yeah, I think I agree. I think we have brachial access, right, PK? So I think putting a wire in the RIMA is not a bad idea from the brachial. Just leave it there. I think vertebral is fine. It's pretty robust vertebral, and the ostium is, and the flow is also still antegrade in the left vertebral. So I think it's pretty okay. The velocities are pretty fine. I think I looked at the Doppler and they showed.
I think the other thing that tells us something is if we're going to get our distal end of our treatment close to the RIMA and it's got disease, then I want to wire it.
Yeah.
You know, if you've got a big landing zone before the RIMA, then maybe not as much.
Yeah.
So we'll see as he gets more pictures in here.
Yeah, we're just getting we're gonna go with now woolly wire from here. Give me a woolly wire, guys.
You know, PK, Chris, and Raman and Vishal. So this disease is like unlike of Takayasu's, right? It's not coming at the ostium. It is subclavian ostium, but it's very weird that the rest of the vessels are so clean, and it's just so focally right at the level of the RIMA. I don't know if it's more of a clamp issue.
Yeah.
They must have clamped the subclavian when they did it because it's such a huge carotid, and that's the only carotid they have. I don't know if this is a clamp injury over time. It has become atherosclerotic. Then the point I'm trying to make is it might be very fibrotic.
Yeah.
PK, that's probably what you might find here. I'm assuming if it's not Takayasu's, and because for atherosclerosis, it's not like diffuse. It's a very focal ring-shaped area.
Yeah.
So you might have tough time breaking it, and even the plaque dispersion might be more.
So let's talk about the use of IVUS here. How does that help us in this kind of lesion to make a decision?
I think it will tell you the amount of plaque burden you have, and that's number one. The other one is does it involve the ostium of the RIMA or not? That's number two. I think vertebral is okay because it's a pretty huge vertebral, but I think the more concern is I think it's going into the RIMA. There.
Right. So I agree. Tell us what you're doing now, PK. You're trying to wire the RIMA?
I'm just getting close enough for you to take a nice picture of the RIMA.
Gotcha.
And, you know, obviously I don't want to mess with the ostium too much. It's a very soft woolly wire. We got to thank Dr. Woolley for making this wire. And obviously it's very hard to hurt anything with that wire, although anything is possible in our field, Chris, as you and I know.
Oh, my gosh,
So right now we're just going to take a picture to show you where the RIMA is. Put it on, I guess, left corner, you guys.
So this is beautiful because we're going to get a good close-up picture from both sides, and you can go back and forth. I like for example, pinnacle destination, 45 centimeter sheath from the brachial gets you right where the action is, and now you've got two axes close to you can work from both sides.
What sheath do you have in the right brachial?
It's a
5-6 slender.
Yeah, 5-6 slender.
DSA, guys?
And you have you just have a IM guide or something?
Yeah, it looks like so.
Non-DSA.
I mean, the other interesting thing, just to complicate this picture even further, you know, there's definitely some disease. Yeah, okay, so there's some disease of right across the actual RIMA. If another interesting point would be, actually, in this one, the RIMA seems actually okay.
So I tell you, PK, this is a time where taking 2 or 3 pictures, really laying this out, from an RAO, maybe a little caudal, and then an LAO cranial to really lay out your origins of your RIMA and your vert, because that's going to be this whole case.
Yeah.
Because
I totally agree.
You know,
so Chris, that's a good point. That was a view. I was surprised we actually got such a good picture. So now I'm going to take another picture in this view. So this is kind of foreshortens it a little bit, right, for us. And
Probably more of a cranial view.
Yep, I agree with Chris. A cranial view may be good. Is he okay, Ray?
Just feels the heat. Yeah, it's okay.
This is going to be the whole case, everybody, because you know we're thinking.
One more, sir.
We're used to seeing right subclavians where you have plenty of room. That's easy. You balloon. The only thing you have to figure out is what length stent doesn't cover the vert.
This is a good view. Okay.
This actually played out well.
So we got that overlap of that non-RIMA collateral that's coming off. Go scene minus, guys. So you've got another collateral coming off the subclavian just distal to the RIMA, which is probably not important. You've got the RIMA that has some moderate ostial disease in the first view. I think the cranial view is the best view, right? Minus one more.
Great.
I think this is the best view. This is LAO 36 cranial 10. And you can see here, you can see the ostium is not occluded, and you can see the subclavian as well. So the issue here now becomes is I think we should IVUS this
For sure.
So what I'm going to do is, since I have this much filling, Chris, I'm probably not going to advance. Or should I? My question to you guys is, because I have the luxury of asking you guys, which is awesome. Is
I would probably advance it.
Would you advance it?
I would probably advance it. Yes, PK.
Now you might want to put a catheter or your dilator in.
Yeah, I'm going to put the dilator for
yeah,
sure.
dilator in and then advance it.
I might even make a roadmap and then just advance on that, and then get as close to the action as you can, because PK visualization here, you're going to balloon, and then we're going to talk about how we deal with this. This is really something. The question is, are we going to cover this with a stent or not? Where are you going to understand? And the IVUS is going to help us.
Yes. So what I'm going to do now is change out my wire. Before I do is, let's do an IVUS now, and then I'm going to characterize this plaque, and then we'll go. So give me let's do an IVUS from the RCA, from the catheter and the brachial. And what I'm going to do is, while he's doing the IVUS, we'll get him an 014 wire, guys.
Yeah. All right.
What I'm going to do is, Chris, I'm going to get the sheath ready to advance. This way, I'll do that on the roadmap. So let Michelle do the IVUS. So Chris, in these kind of cases, you want to do a roadmap?
Okay, sure. I don't want to go into branches.
I'll do it right now. Ready?
014.
So let's do this. Let's do a roadmap.
Yeah. Ready?
1 second, guys.
Yeah,
Let's do a roadmap.
This is definitely going to be answering a lot of questions. I think it really does go to show once again that case planning in itself, you can talk about all you want before you see it, but once you have your pictures, then you can really make your full plan. Yeah. I mean, we were always talking about the protection devices for stenting. This could be a case where just maybe even just like an off-label DCB may be enough to really treat the disease safely.
Yeah, Ramus, I'm glad you brought that up. I was going to save it for later, but since you brought it up, this is a great time to think about it. This is a big vessel. The IVUS is going to tell us this, but it's going to be at least 9, 10. It's going to be probably 10, 11, 12. Yeah. All right. So then I if there's disease by IVUS right at the origin, then I think this is a time where you would think about a off-label, as you said, DCB that you use in the AV fistulas, for example. Yep. They make at least 10 millimeter DCBs. And remember, we've got a Takayasu's process anyhow, as you mentioned earlier, Karthik, that this may be a different animal to begin with. And then we'll have to worry about, is there any risk of embolization for DCBs when we're working on that close to the right vertebral artery? Probably it's low, and I think it's less than the risk of covering it.
Yeah. I think those are very good points.
For me, Chris, I mean, we got to think about what the patencies of subclavian stenting are. And while we do the IVUS, I'm going to go to I have our fellow prepare something about subclavian stenting, so everybody can also do. Can we go to the slide set while we do the IVUS, and then he can present it, and then Chris and the gang can talk about it. So let's go to the slide set. Go ahead, buddy.
Okay. So I just have a few slides on the epidemiology and disease process of subclavian artery stenosis. So about 2% of the population has the disease. Majority of these patients are asymptomatic due to slow progression until, usually it's more than 50%. Atherosclerosis is the most common cause. Other causes are arteritis, inflammation due to radiation, such as some of our breast cancer patients. We had a case of that last week, compression syndromes, and FMD as well. The vascular risk factors include kind of all the normal culprits, usually diabetes, hypertension, hyperlipidemia, smoking. All of these promote that process of cell adhesion to the molecules, causes inflammatory cells to adhere to the arterial wall. That leads to remodeling and lipid deposition in the tunica media, which causes narrowing of the arterial lumen and calcification. The brachiocephalic subclavian can also be affected by vasculitis like Takayasu's and giant cell. Oftentimes sparing the carotid, and the brachiocephalic atherosclerosis can be unifocal or multifocal and can manifest as a variety of symptoms: TIA, upper extremity ischemia or claudication, or vertebrobasilar insufficiency. The left subclavian tends to be a little bit more common in right subclavian in the atherosclerotic disease process. Arm claudication manifests as muscle fatigue, rest pain, and in extreme cases, finger necrosis. The neurologic symptoms include visual disturbances, syncope, ataxia, vertigo, dysphagia, dysarthria, and facial sensory deficits. If the lima and RIMA are involved, as in our case, you have the so-called coronary subclavian steal syndrome, which manifests as angina. And typically, these patients will have an unequal blood pressure, typically 20 millimeters of gradient between the left and the right. They'll have refractory hypotension if both subclavians are involved, rarely. Faint radial pulse, bruise, ulcers, nail bed splinter hemorrhages as seen on the picture on the right, oftentimes an ABI greater than 1.3 in patients that have bilateral subclavian artery stenosis. The evaluation includes something as simple as just doing BP measurements in both arms in clinic. That's usually the first step. And you want to assess for bruits, carotid, cervical, and supraclavicular. And really the imaging of choice is duplex ultrasound with color flow. You're going to see dampened or monophasic waveforms, turbulent color flow, imaging and increased velocities in the region of stenosis. And as you can see on the left in our pictures, reversal ipsilateral vertebral flow consistent with subclavian steal syndrome. CT and obviously angiography help with measurement and sort of planning of the procedure as well. There's a lot of variety in subclavian anatomy, A being the most common, D the least common. A is just a normal arch in the aortic arch with the three main vessels coming off the top. And B, you have the bovine arch with the left carotid coming off in the proximal portion of the innominate. And C, you have the so-called truncus bicaroticus with the left carotid coming off a little bit more distally near the right carotid. And finally, in D, you have the left common carotid coming off the left subclavian. This is important because this is the types of arch 1, 2, and 3. Typically, we do these as an endovascular first approach with the subclavians. However, if you have a type 3 arch, which you measure by drawing a flat line at the top of the aortic arch, at the most horizontal kind of portion of it, and then another horizontal line through the ostium or origin of the innominate. And that distance becomes more than 2 centimeters, considered a type 3 arch, making it much more difficult for catheter engagement, support, and so forth for an endovascular approach. Type 1 is obviously most favorable. The treatment for these patients, the symptomatic indications for treatment, symptomatic, obviously they have TIA, CVA, the coronary subclavian steal, ipsilateral hemodialysis access dysfunction, or impaired quality of life due to symptoms. And the asymptomatic, someone who's planned for a CABG, again, ipsilateral hemodialysis vascular access, or significant bilateral subclavian stenosis and need basically for BP surveillance. Typically, endovascular first is reserved. There's not a large randomized trials comparing open versus endovascular, but the risk of complications, including vertebrobasilar stroke, is low in both approaches. And the major complications with endovascular include plaque shift to the vertebral, CVA, and distal limb embolism. This is a paper from 2015. It's a single-center retrospective study of patients who underwent subclavian artery stenting between January of '99 and December 2013. At 10 years, the freedom from ISR was 70% and freedom from target lesion revasc was 82%. It's pretty good. And risk factors for ISR in this study were smoking and COPD with the hazards ratio 3:2, a vessel diameter less than 7 in the subclavian, and favorable factors were right-sided intervention and discharge on statin. The surgical techniques include a carotid subclavian bypass most commonly, and then axillary bypass or transposition. Typically, again, these are reserved only if an endovascular first is unsuccessful. And these are also considered relatively safe, mortality less than 2% and stroke risks less than 3%. I'll just conclude the post-op follow-up for these patients is, like all our PAD patients, you want to control the risk factors, smoking cessation, statins, beta blockers, and aspirin. Post-stent, we typically do DAPT for about 3 months for these patients, aspirin obviously lifelong. And then surveillance, duplex study every 3 to 6 months for the first 18 to 24, and then annually after this time period. Thank you.
That was fantastic. So, Chris, we're playing the IVUS. We're really not getting good images, which is interesting, but we can see the proximal and the most diseased segment very, very tight, and then you can see the distal subclavian.
So we're not seeing that right now. There we go. Thank you very much.
We're going to put it right up again. You're going to see the innominate. You're not seeing much, and I'm going to kind of read it off to you. So right now we're starting in the innominate just near the catheter, meaning our sheet from below. That's the innominate. That's the wire.
We can't see it. It's the gain is too low for us.
I know.
Yeah, that's how it's recorded.
That's how we got it.
This is an 0-4, 0-8 IVUS.
It's an 0-8 IVUS.
0-4.
0-4.
Yeah, it went through a
0-8 IVUS.
Yeah, it was an 0-8 IVUS.
And we're going to do it with an 0-8 IVUS. So Chris, we'll do another IVUS. Yeah, I thought they gave me an 0-8. We're going to do an 0-8 IVUS. We're going to increase the gain, and we'll run it again. The question here is, our ACT was 275, came back at. I think that little thing that was moving was the wire. We'll double check it. Waveforms are good. My question here is with those patency data that Dr. Jaffer so nicely put together, and if we know this is burnt out atherosclerosis, and we know that this could be obviously injury through the clamp, would it just be smart just to do a bare metal stent, balloon angioplasty it, or cut balloon it, and then, since it's an aortosteal sort of lesion, and then go ahead and not aortosteal, but an ostial lesion, and then go ahead and put a stent?
Right. So I think great questions. I think first of all, the restenosis data is tainted by people who put stents that are too doggone small.
Yeah.
You know,
Right.
Yeah.
is first of all, the left subclavian is always 8 or more, and the right subclavian bigger than that, as we're going to see on IVUS here. So I think PK, the important part here is remember that this is Takayasu's. Even though it's burnt out, we want to be a little bit careful in this big artery. You are not allowed to rupture this artery. Okay.
Oh yeah.
So that's, and because you think of the covered stent options here, taking out the right vert and the right internal mammary artery in somebody who's left carotid, left vertebral out, and he's got a RIMA, excuse me. So you're not allowed to do that. So
and
with
the diameter.
And with that in mind, the question is going to be from this IVUS, how close are you to the origin of your other vessels? If you're very close, I personally would go with a scoring balloon strategy to be gentle first, and then a big DCB and a long inflation, and see what you get. You don't have to stent it the first time, and if you did stent it, it would be a big nitinol stent. That way, if you covered the ostium of these, you can still, the interstices, you can get in there very easily to fix it. In fact, you can even protect it when you do this before you post-dilate.
Yeah, because this guy obviously does not only have, Takayasu, but he clearly also has, intrinsic, like true atherosclerotic disease.
Yeah, they need to ring down also. Ring down, guys.
Ring down, guys.
That he's going to need further interventions from a coronary perspective for this RIMA are not nil.
There you go.
So,
and one increase in
that's good.
Case planning to make your next steps easier, just in case, is also very important.
So guys, right now we're go a little forward, Vishal. We're going to start recording. Yeah, that's the wire.
There we go.
There we go. So now we're going to, this is the innominate, probably innominate level. Now come back.
Start recording.
So we start recording. So he's pulling back. I can even do it on a roadmap if you want. This should be getting to the ostial of the subclavian right about here. We're starting to see the lesion. It's very tough to see. There you go. Yeah, this is ring down, and this there you go. And that is,
that's better.
That's the ostium subclavian right there, and that's the lesion. See that?
What soft plaque?
Yep, soft plaque, no calcium, and that's what I'm worried about, plaque shift, and that's the distal subclavian.
Now, is there any way, PK, I think what would be very helpful is if you could show us the imaging, the fluoroscopic imaging, ideally even with a roadmap, so that we could get a sense and match up your IVUS to the origin of the right internal mammary and all those. I think having those pictures at the same time is invaluable to all of us, so we can pick whether we stent.
I totally agree. So what I'm going to do now is I'm going to have them. Can we get 2 screens up? Our technical team.
Yeah, this is very helpful.
We're going to get 2 screens up, and then what we're going to do is we can't see it from here, but you guys will see it from there, because obviously we don't, as many bells and whistles as you can have. Sometimes you don't get everything you want, right? So I'm going to give you this this roadmap picture now. So
let him change the settings first.
Change the settings. No,
the screen.
What screen settings? He's just roadmap's going to pop up. That's all.
No, but
we're not going to see IVUS.
Oops.
I'm going to do one more time here. There's not enough contrast. Again, I'm being extremely paranoid about air and thrombus.
No, you're being careful and protective. That's what you're doing. That's not paranoid. That's an experienced operator.
So, Chris, right now we've got the
yes.
First of all, can we see both?
Well,
can you see?
We see a still image on your IVUS. It's kind of yep, and we see your roadmap beautifully.
All right, good. So now we're gonna go distal with the IVUS.
Can you go live on the IVUS?
No, go distal first.
Sure.
We're gonna go distal. Stop. Okay, a little more. Stop there. Okay, go live on the IVUS. So there, now you happy with the gain and the diameter?
Yeah, I would increase the gain a little bit. Increase the gain.
Increase the gain, guys. Keep going.
And adjust image to get as much as you can. If it's you should get at least.
Go back one.
That's good.
Image of 24.
That's good.
24, guys, go to 24.
24.
With the image.
Yep. Adjust image.
That's
there you go,
max.
right there.
Yep.
Yep. Max
24.
There you
Yep.
go. That's the max.
Yep.
So now we are in the innominate, as you can see. Now pull back slowly, Vishal, and record. Okay, we're coming back from the innominate. So you can see that's the innominate artery, very poorly seen because it's a huge artery. And then as we're coming forward into the subclavian,
proximal is okay.
That's a proxubclavian. And now you'll start to see the beginning of the lesion. The beginning of the lesion, and now you'll see the lesion very, very tight. A little bit more. Keep coming. There it is. So except there it is, right there.
That's tight.
Wow.
Very tight, and that's distal.
Right over the, you actually see
And
the
that's
ostium
distal.
of both the vert and the RIMA right there.
Right there.
Okay,
so,
good.
So you
Okay.
may have a little landing zone.
Stop recording.
Yeah, you
Not
have
much.
a tiny little landing zone.
I mean, it's a Tennessee Gnats hind end landing zone.
Well, I mean, the other question is that if you have that little of a landing zone, if you target your ballooning so much to just that area, what's the concern for possibly tooth pasting out into the ostium of the other?
I wouldn't tiptoe around it, quite honestly.
Yeah.
You know, so let me ask a provocative question, PK, and I know the answer, but with all this being so close, is there any thought of surgery here with the guy had a left common to left subclavian, by the way, it's occluded. Would you put him through surgery? He's got so many other risk factors. He already have an angina. So I'm not sure it's a good idea. But what do you think? Is there any thought at all for right common to right subclavian bypass? Or do we just do a very careful, excellent procedure that we're going to watch together?
Well, I mean, you're absolutely right. I mean, there was plenty of thought given. Obviously, he's been explored multiple times. And, you know, at this stage, there was a little bit of hesitation on our surgical colleagues' part. And honestly, Chris, I think, you know, for this, we felt like this is the sort of the way to go. And the reason is because you've got too much going on. The clavicle would have to be obviously dismantled. I don't think it's an easy surgery to pull this up. And also with the cerebral events, what would you clamp? Would you clamp, you know, and so on and so forth. So I think with all that going on,
RIMA too.
with active anterior ischemia, we felt that, you know, whatever we can do to help this gentleman, it will do. So you can see here, we've taken dual pictures. We've got, I'm going to move my wire up, obviously, into the arm, like you suggested, Chris, not to be on the soft part of the wire, on the 035. And now you've got a beautiful picture where you can see the ostium of the vert, you can see the ostium of the RIMA, and you can guess where the ostium of the subclavian is.
Yeah. Now and you can always move your camera twice. You can position your distal end and then come back and then go back and forth so you can see both ends. But this is a beautiful demonstration, PK, of all the thought that goes into treating this lesion and all the, you know, what we're protecting with. So once you get up there, PK, what are you thinking now? You're pretty darn close to the origin of these important vessels. Are you going to try a balloon alone strategy, or are you going to try a nitinol stent that just you go ahead and cover the lesion with a nitinol stent, or are you going to try to be very precise with a balloon expandable, say 10 by 19 or 10 by 18? What are you thinking here?
I think the stent of choice has to be a balloon expandable because you want to have precision. So therefore, I think we are going to go with a balloon expandable here. So the only question is whether having a balloon expandable would be the way to go. The other question is, I'm keep getting into that second branch here because I do want to wire protect. I think with that amount of soft plaque that we saw, the only question here is, you know, do we balloon angioplasty and leave it? The question is, if we balloon, we got a bad tip here. If we balloon angioplasty and leave it, there we go. Oh, I thought I had it. The balloon angioplasty and leave it technique may not work here because are you going to bring this guy back and deal with his restenosis again? So. So we're just gonna, you know, I think if we're gonna do it, like, you know, one of my teachers used to say, the poop will get off the pot. I think we need to take a poop here in a good way. So I think that, you know, we're here. We made a decision. We've IVUS'd it. I think we got to give the best definitive therapy for our patient that we possibly can, and that's going to be the issue.
No, I agree. So while we're pooping live here, let me ask my colleagues here.
Short break.
So Raman, you had mentioned DCB earlier in a discussion, and they make the 9 and 10 millimeter DCBs. Do you think that works here at all or not? You know, does that help with the Takayasu's? It's a big artery. Would you do that if it looks great? Leave it alone, or would you stent it?
Put the wire down.
I think after looking at the IVUS and seeing that much plaque burden, I feel more confident that this is not truly a burnt out Takayasu's. I haven't, you know, I'm not too familiar with the literature of you know, DCBs and like what we're now presuming to be clamp injury, atherosclerosis. But I think if you just kind of extrapolate from your peripheral data and you choose to kind of believe that same kind of concept of, you know, decreased restenosis, I think you can make the argument that this will likely stay patent for long enough. The question is, do you feel comfortable without a scaffold here?
Yeah.
You know, and I don't think I feel comfortable without a scaffold.
I think we're all saying pretty much the same thing. And the DCB is going to be a 40 length. And boy, if you cause a dissection, now you've changed the game completely.
Also, we don't have the 9 DCBs.
We do.
We got them here.
Yeah, we do. If not, I'll bring some from Kingsport next time. But, because they really, there are a couple companies, Medtronic for sure, Lutonix make them, and I'm sure others. So I apologize to any otherbody.
I don't know, because I think the vessel size is so large. I think the stent is going to be such a large stent, and I think the patency rates are going to be very, very high for the stent.
Now,
the
only question is
so
let me do a bigger.
So we're just going to wire this with the this one. I'm just going to move my guide up a little bit to get it to point down. I'm just going to use the 0-4 wire as a.
Question is, would you do a self-expanding or a balloon expanding stent?
So it's a good question. If you think there's a distal landing zone, then I'm with PK. I want the precision in the radial strength of a balloon expandable stent. And then you're going to have to get, it's going to be at least a 10. And then the companies make 10 by 17, 18, and 19. And it's going to be one of those ranges. If I thought I had to cover, then I would use nitinol, because I think nitinol has bigger interstices to get in. And before you post-dilate the nitinol, you can put a wire in your vert, you can put a wire in your RIMA, although the RIMA, as was mentioned, this is a crazy bad angle into the RIMA. You may need a deflectable tip catheter or an angulated catheter if
like
you're going to truly wire it. Or you can always wire it potentially from below if you needed to, and leave a wire in with an 018 wire, because you've got an 8-French sheath. So if the wire is crazy from above, the other option would be to see if it works from below.
The angle might be more favorable from below.
And so if you don't have an angulated catheter, if it doesn't work from above, I'd go from below. And then the other thing is, do you just go ahead and get to work and
finish it off
and deal with it afterwards?
Yeah, because he's got in there.
But that I think it's the other branch there, Chris.
Correct. Not the RIMA.
That's a very tough angle from above.
Yeah, that angle kind of, you know what? It's not a very favorable angle here, even with a.
It's a retro angle.
Let me try to pull this forward over this catheter. Let's try now and see whether we can pop it into the RIMA somehow.
Or we keep this wire and put another wire next to it to give it support.
Yeah, it doesn't seem to want to go. I think Chris is right. It may be easier from below, because actually it was funny, Chris. The woolly wire went, remember?
Well, and if you go with a woolly, I want you to be very gentle,
exactly.
Because
you know what they say, PK. Better to be lucky than good.
Absolutely, we all believe in that.
And when he's both, that's a good thing. So he's
So I think we will go from, like you said.
There we go.
There you go.
We just had to say it a couple of times. Take your time manipulating down here, because right now you can prolapse it right back up. That nicely done.
I'm going to leave it there, and it's prolapsed up, as Chris said. I'm just going to try to torque it down now and just leave my guide kind of where it is. Can I get a forcep or a torquer to put on this so this wire doesn't move and we have it protected? So now we have the RIMA protected, at least with the thing. And now the question is, pre-dilate, don't pre-dilate, just balloon stent, sizing, so on and so forth.
So I would pre-dilate all day long, every day, 24/7 for several reasons.
Agreed.
One, it's going to make your life easier. Number two, it's going to give you so much more information in terms of length. So if you take a 20-millimeter balloon, you're going to get diameter, length measurements. You're going to see how the lesion reacts, and then you're going to make a better stent decision. So,
something on top.
And then the only other question: would you use a focal force? Like an 7 by 20, 8 by 20, say ultra score, for example, comes over 3.5, just to have less chance of dissection, or would you just do a slow balloon inflation and somewhat undersized?
Because I still don't know if it's completely soft plaque or there's a lot of fibrosis in there.
Fibrotic in there, exactly.
So because it looked a little bit more dense than a soft plaque on the IVUS. So I think pre-dilatation will give you an idea if there is if there is going to be a waste.
So then a 20 balloon is okay with you? And
yes.
I think so. I would probably go with an 8.
And CT
they were 10.
I would probably go with an 8.
So IVUS was 10.
First.
Okay.
IVUS was 10. Your CT was 12. And so I think if you did a gentle 8 by 20,
probably would be better.
Give me an 8 by 20 035 balloon.
Yep. Make sure it's a long shaft.
Yeah. So Chris, I also have the Viatrax, the 6 and 7 15s.
Yeah.
So those are smaller than the 20. I don't want to have to keep changing wires because I don't want to track a balloon expandable
I think
stent
this
over
is
this.
fine. 820 is,
Yeah,
820
so
is
you've
good.
got an 035 wire that you're going to be working
Yeah.
over. So the VHX 014, obviously. So I personally would just go with your 8x20 035 device, whether it's a balloon or a scoring balloon, your call. And I would take a picture with a balloon in place so I really know where it is. And what you could also do, PK, is try to get that distal end with your balloon. When you have the balloon up, then take a picture from the arm with a balloon up. That'll tell us where the distal end of that, are you right where you think the distal end of your stent's going to be relative to the RIMA and to the right vert.
So that's a great point, Chris. And I think that's, again, something that with your experience, it really is an awesome point for us, because I think that tells us exactly how far we are. And I could take a proximal and distal because, like Chris said, we went with a large a lumen catheter. So I'm in the wrong view. We did a large lumen catheter, so this way we can inject around the balloon. So what I'm going to do now is go ahead and set up my shot, which is cranial, as we talked about before.
Yep.
And now what we're going to do is we're going to get
So
it ready.
that wire gives us an idea of where the distal end is going to be.
Yeah,
Right?
Exactly.
What you could do is bring that sheath up a little closer over the balloon. Use your balloon as a dilator, halfway outside. Bring it up a little closer so you can see from both views, so you're not getting washed out in the common carotid. And then get your balloon exactly where you want it and take a good picture there.
There you go. So at least we got a reasonable picture, and I'm going to do that in a sec. So we're now going with the balloon, and you can see the RIMA ostium. And I'm going to kind of do exactly what you said. Place it and take a picture through the arm as well. Yep. So this is a 100 shaft balloon or 110 shaft balloon, if I remember right. Keep going. You're not there yet.
No,
they should be at least 130, 135, I would hope.
No, you're not.
No,
that's this one.
Oh, that's the wire.
Yeah.
Okay. I just got for a second.
So here, Vishal is just bringing up the balloon slowly. There it is. Keep going. Keep going. Don't move, sir. Keep going. I'm going to stop it right there, Chris, for now.
Yeah.
Okay.
You can feel the resistance.
PK, I see the soft part of the wire which came back because I see the dark part.
Forward now. There you go.
Yeah.
There you go.
I think you might get more.
That's good right there.
Yeah.
That's good. Yep,
that's probably the
we're
resistance.
Now. And that's a very tight lesion. And so now, so we have the wire for everybody to. My only question before we do any of this is, guys, is what are the options now? God forbid RIMA closes, so on and so forth. So what are the things we're watching for? So I'm just going to take a picture from the arm.
We can always stent the RIMA, so ostium. So you have the wire there, so you can always stent the RIMA ostium.
I think it's good.
We probably need to go. No, I think we're good there, Chris.
I think we're good.
Yeah, I think so.
I think you may have to go in.
Go a little bit in, but I think it's fine to start there.
But the shoulder of the balloon is going to stick out.
Yeah.
Right.
Yeah.
So I think we're okay. But the wire, you can see the ostium is further back.
Yeah. And you may have to take two views to really lay out the origin, but
that's what I'm doing now.
And that's something you've taught me during many a live case here, my friend. So I'm repeating your own words of wisdom.
Well, listen, I mean, that's a good point. I'm glad you reminded me, because I think I've watched, obviously you as well, and it's incredible how the lies that the angiogram tells you, right?
Yeah.
So there's another one. So you can see here, there's a little bit of overlap.
I'll probably go in a little bit.
I think we got to go in a little bit, don't you?
Yeah.
And then just go up slowly and then take your pictures. This is just a great demonstration.
That's good. Yeah, I think so.
A little more.
No, I think we're good.
Ooh, there's no flow in the vert now. See the slow flow in the vert?
Yeah.
See, so we were occluding the vert, Chris, when we went forward.
Yeah.
Wow.
So that you don't want to horse around. You'll get your take your picture and do your balloon and take your pictures. You'll be okay.
I agree. Okay, so I'm going to move it forward again. Let me set up the shot.
I mean, you have the other side vert through the graft, so.
No, the other vert's occluded. It feels retrograde. Yeah, the left subclavian's out, the graft is out, and the left ICA's out. So he doesn't have horse around time. He's going to have to, what did he say earlier, poop, get off the pot, but not spend a lot of time pooping.
All right, I like that, guys. You agree?
Yeah. That's good.
You have to pull back your guide from your brachial. It looks like you're pretty close there.
Yep.
Hold on. Pull back the guide, Ray.
Good call.
Pull back the guide.
So you've got two eagle-eyed partners watching both your wires and your guides. This is teamwork on Mount Sinai style.
I like that. So it's soft plug, PK.
I am.
You were able to expand very well, actually.
Yeah.
Go forward more.
I think it kind of watermelon day.
Okay, hold on.
Yeah.
It did.
Yeah.
It did. I'm just going to inject again. Okay. Okay.
That's good.
Yeah, I like
Too
that.
much.
Okay, let's
Too
just
much.
walk
Too
this
much.
back a little bit. Okay, go up now.
But you can see the flow hanging around a little bit in the
Positive.
vertebral artery, and that's a.
Makes you clinch.
I'm clinching right here.
Oh, there you go. You see that?
All right, and then take a picture from the arm when you're ready.
Okay. Taking a
Definitely,
picture
so
from
definitely
the
a little bit more
Fibrotic, yeah.
fibrous than expected. Still watermeloning.
down.
PK, I think it did slip back.
I agree.
I think you still have room to go forward.
Okay, let's go forward. No, we just like Chris said, we'd go a little more.
Yeah.
The guide has to come back a little bit more.
No, the guide
I think
is
the
good.
LAO view was better.
Just
There's an
checking.
overlap. Yeah, the LAO view, you had the 17.
Yeah, that's good. That's good.
Figured out a couple things here. Do we agree?
Vishal,
that
you want to
the
keep forward
balloon-only
tension?
Approaches
Hold on.
Yeah, I am. I
likely
have
off
forward
the
tension.
table
on
now,
there.
considering the amount
Yeah,
of
that's good.
watermeloning we're.
I think
That's good.
here.
That's
I
good.
think we go, right?
No, that's
Yeah,
good.
fine.
I would go. Go
Go.
for it.
It's foreshortened. That's why I agree with
Yeah,
Karthik.
yeah.
But then we'll need another picture just to see.
There's a lesion.
There, that's your lesion.
Wow.
Yeah,
Go to 6.
that's fibrotic.
It is.
Yeah.
Now I will tell you,
got it.
going back to your question, Raman, I am a little more concerned about putting a balloon expandable stent, and the last thing you want is a dissection at the distal end
Yeah,
of it.
yeah.
I
go with the
actually either
self-expanding
would
stent.
think about a balloon approach or putting a large nitinol stent and just going and covering it.
Yeah.
I think a 12 or 14 millimeter, 30 millimeter nitinol stent is going to be just
Hey
fine.
guys, what's happening here? I don't know.
Change the subtraction on. Hold on.
Subtraction on is all.
I'll probably put a self-expanding stent.
I
At
think
this
now
point,
I'm changing.
Because I think we expanded it, we broke the lesion, looks like.
Yeah.
So I think we have
Oh, no,
room.
don't do. Why is bolus here?
But
Why
you
is my
want-
table
hold on.
locked?
You
Okay, now
want,
go.
so you want stability
table
of this
lock?
lesion.
Dr.
And-
Metzger, a question.
Yeah.
I mean, I don't know the answer for this, but you and PK have more experience. The balloon expanding stents, do the stealth studs differ from balloon expanding stents to a nitinol
Absolutely.
stent?
And one of the nice things about the nitinol stent
Dual
is
injection,
the
you inject from
interstices
here
are
to
large. You
Yeah.
can very easily get an
Rewire.
014
Wire
wire.
For
through it.
wire across.
And you can put
That's
your
what I was
nitinol
asking.
stent in, and then before you post-dilate the nitinol stent, put your wire in. It's truly protected, so you
Yeah.
don't have a trapped wire.
Got it.
But Chris, in terms of the nitinol step and position, don't you think that position-wise, we
have the arm.
can inject?
So-
Right? Hold on.
Ready?
But they now.
I think you have room, PK.
In
So
this case,
now-
you,
so
you
here-
willingly choose to go distal now.
So
Yeah.
here's the
One more
question,
time.
PK. The question is, are you going to cover? Do you think you have a landing zone before your important arteries? Then I go balloon expandable.
Yeah.
If I think you have to make a coverage and you're going to cover them,
Ready?
and I want to cover them, then I'm using nitinol.
Yeah, and do
And-
so safely.
And so this
With
is
a
so
little margin.
challenging to know exactly where things are. The other thing that might be helpful would be to IVUS the right internal mammary
The
ostium.
Lima is
Yeah,
good.
the RIMA is okay. PK, I think
So
RIMA
if
is
the
good.
RIMA's okay. I might. So what do you think, PK? Are you thinking balloon expandable, try to nail the distal landing, or put
I
a
think-
14 nitinol stent and just cover it?
Well, my only worry is we put a 14 nitinol. I agree with you. You definitely get a lot coverage, and you get the mismatch is fine, either proximally or distally, and you're not going to dissect. The only question I have with the 14, you figure the lesion length. This was a 20 balloon. It was probably like a 17
Correct.
lesion length or a 9. So
Yeah.
the question is, you're going to end up putting a 30 or a 40. And are we okay with that? Which I am okay with it as long as there's
Yeah.
no issue with
Oh,
flow.
I think so.
So
Yeah.
that's a
So-
question for you guys: is do you think you can nail it without covering the RIMA? If you think you can, that's when
Yeah.
you'd use your balloon expandable stent.
Yeah.
If you're going to cover it anyhow, then 30 gives you. You're right. It's a 20. It's less than a 20 lesion, but you'd go from the proximal subclavian, which we know is normal, across the RIMA into that big fat. Right
Yeah.
subclavian in the post-vertebral
The only,
segment.
the only
The
other
question
question
is
Chris, is
re-intervention
radial
of-
strength also is an issue. And the radial strength of this, we know it's not very calcified, but the idea would be 270. All right, get 500 more of heparin, please. So what I want to do is now decide with you guys, looking at the last two pictures, and make a group. This, like I said, I'm spoiled. That's why do you think I called Chris to come all the way from Kingsport? Literally begged the guy. He loves New York. I know he'll come, but the point is, this is a lesion that is not an everyday lesion.
All right, here's what we could do, PK. I see your partners, and by the way, beautiful work. Even during this case, we hear the quiet, give more heparin, kind of paying attention to detail. No, seriously, that's important for operators. But you could go the PK approach and do this. Do a balloon expandable stent here with a provisional bailout of a nitinol stent to add to it if you needed to. So if you are all very more comfortable with that, then you take your 10 by 18 balloon expandable stent, nail the distal end, have a nitinol stent in the room so that if you had a dissection, then you add to it. And I think you'll be okay with that approach.
My only fear here, Chris, is that when we put the balloon expandable stent, okay, we won't miss it. I just think we'll partially cover the vert. We won't fully cover the vert. And the issue is, if we partially cover the vert, is that going to be a problem for us when we try to re-intervene on the vert? So I'm kind of leaning towards the self-expanding, but it's one of those situations where ostial lesions were taught to use self-expanding, but in the iliacs, obviously we can't extrapolate data. The ICE trial clearly showed that self-expanding may be better than balloon expandable in this ostial lesion. So I'm kind of torn. I mean, I could do a 10.
If you ask my opinion, I would personally go with a nitinol and just cover it because you're safe. It's a big lesion, a big artery. You have good ostium, as you said, Karthik. The RIMA's fine. Yeah. The right vert is huge.
Right.
And so if you
and
take
the stent sets are also big. Stent sets are also bigger.
You're okay. I think you offer more danger by trying to. If we cause a dissection with the distal end of a balloon expandable and it dissects in that vert, then we're going to be in a world of hurt.
Yeah. The only thing I'll say,
the question is stent sizing.
Back one.
Sorry. Go back one for Vishal for him. I'm just looking for the stent here. I'm doing what Chris does in the live cases. He goes and gets the right equipment. That's what I'm doing.
Yep.
You had a picture with the balloon up.
Let me see if I think we fluoro saved it. Hold on.
I think hopefully he did, because we did see it when he was positioning it.
One of the things why I think that picture is really important is that when the balloon was up, the RIMA and vert were both closed.
Can we go to the
and
OR and get a
that was one time that we caught the actual lesion.
No, the lesion goes across both the ostiums. So there's no doubt about it.
I'm not sure even if it is even possible to really hit the true.
And I think we're going to be more trouble by trying to get that cube. And the distal end can cause a dissection, and that's a disaster. So why not just go with a nitinol stent, cover it all?
That's the plan.
So the question here, Chris, is I agree with you, but do you anticipate recoil after balloon? The gradient went from I think 40 to 20. It's a 20 millimeter gradient now. It was actually a 40 millimeter gradient. Now it's 20. So my question to you is: do you think here the IVUS measurements are 10 by what is the IVUS measurement? 10 by 8.
10
by 8 or something. Yeah. So the question here is: would you go with an oversized stent, but God forbid the stretch reflex and having the restenosis because of stretch, or would you just go with a properly sized 10 millimeter, knowing that the distal subclavian is definitely not 10 millimeter. The proximal may be, but the distal won't be.
PK, I would go with 10 millimeter stent here.
A 10 millimeter nitinol?
Nitinol, of course,
maybe 10 millimeter nitinol.
12. Absolutely.
I would go with at least 12, but either way, it depends on what you have too, because if you're going to go 12 or 14 smart control, you better have a long shaft lesion because you've got a shorter, smaller sheaths in your brachial. Yeah. But an Absolute Pro or one of the other nitinol stents would go easily through an 8 French, and you're going to have a 135 shaft length on your shelf. Yeah. It's kind of equipment what you have there, PK.
I have a 12-0, a 30 or 40 Protege. I have a 14-0 Protege.
Yeah, I would probably go with that.
I have a 10-0 Abbott stent. I don't carry the quarter stents right now, so therefore, we do have a lot of other products here that we could use. So the issue here is, going with a 12, 30, or 40. I think 30 should be enough, right? I think 12, 30, and just landing it away from the ostium.
That's what I would do, is pick your 12. You want to get around that curve. A little bit in the subclavian right there. So if a 30 is going to get you, I'd have your staff bring in them both. I'd put the 30 in. If it was too short, I'd take it out and put the 40 in.
We only have a 40, so we're going to go with the 1240, Chris.
Then I'd go with the 40.
So let's get the 40 ready, guys. 1240.
That's what we're doing.
So you know what, PK, you have brilliant staff and supply chain. They're getting you 8 French. They're not giving you a 7. They're not giving you a 30. This is Mount Sinai at its finest in teamwork. I mean,
Chris, you're right. I've seen you operate. Your team is incredible, and you're only as good as your team. You're absolutely right. I mean, having Vishal, me, Karthik, and Raman have such a great team, and I think it's just it's phenomenal to have these guys who've, a lot of them, like your staff, have dedicated themselves to vascular and valvular, and really they do coronaries, but they do more of this. And as you need that expertise in the picture. So Chris, 2 questions. Vessel prep, and this is a great question at a conference this weekend that I was telling you about. They had a lot of discussion on this. How do you gauge vessel prep? So, what is your measurement of vessel prep? I mean, how do you do it? Do you re-IVUS? Hold on, guys, before you go in.
I'm not going to go in.
Do you look at gradients? What do you do for vessel prep? I'm not going to re-IVUS, obviously, now.
Yeah, no, don't. But for this, your prep is only to make it was to give us information, how long and how it's going to respond, how close we were, and you're going to stent this. So 8 was plenty. You don't need to do anything else to get too cute. You've prepped this. The vessel prep is different if there's calcium and you're trying to DCB only or something like that. That's a different discussion. For this, you just wanted to open the balloon, get your information, and then stent it. And I think you've prepped enough.
So we'll do another one here because I'm stealing through I'm just stealing through the carotid here. I'm just going to do another one.
Agree. Yeah. Totally.
Now.
Yeah. Just put the stent in and that's it.
Perfect. Okay.
Definitely so across the bend.
Osman is going to rail him, and we're going to go in through the stent here from below, and I'm going to inject from above when we're ready to make sure that we have it across the vert. So as we go, you're good. I got it. I'm going to have Vishal. Don't move, sir.
That'll just be an interesting point.
It's very crucial.
Say,
don't move.
For example, for the sake of argument's sake, that there was some moderate ostial proximal RIMA disease. Protection of the RIMA, filter, balloon. Would you do anything else besides just the wire?
Good question.
Go. So this is a 40. So like you said, it's awfully big, but that's okay. A little bit more.
That's fine.
No, that's perfect.
That's perfect.
I'm telling you,
exactly
Mount Sinai at its best. so brilliant.
So Chris, I want to, like you said, I'm going to go to 2 views here.
Yep.
To look at pull the guide back a little bit, guys. Slightly. Watch the wire.
Right to 5. Yeah.
No, from here.
This is good. Yeah.
Bring your
wire.
bring your sheath back to the arm a little bit so you don't stent it in place.
There you go.
There you go.
Tie this up here so this doesn't go. So now I'm going to inject from the arm with this.
Right there.
So just going to see where we are. I'm sure there's going to be poor flow in the vert like it was last time.
Okay. No, there's not. Okay, you've opened. Okay. See, there's your vessel prep answer. Yeah. So you've prepped it enough that seriously, you can see the vert just fine. And then
we're going to inject through both now, and I'm just going to go to a little cranial view, not too cranial.
PK, can you push the sheath a little bit forward?
I think we're good here, Karthik. I think, I just want to, I think the stent is across,
we need a little bit of space,
and I think we need to see the ostium very well. So let me see. I'll definitely adjust if this picture doesn't look good. Ready? Yeah. Mm-hmm. There you go. Do we need to
pull back?
Yeah,
we got to go forward a little bit, huh?
Yeah, that's why. Yeah, that's why I thought the sheet might give you an angle.
So PK, from there you get one look. Go to your RAO caudal. Because what we really want to see now is the proximal end of your stent.
Yeah,
agreed.
Right.
And so let's take a look at that in another view.
So I'm at 20/20, Chris, the standard view that we always use.
Yep. And sometimes even more RAO, but let's see if the 20/20 Barbara Walters works.
Yeah, exactly. Let's take a shot here. I'm just going to do a DSA here for us. So it's hard to tell in this view.
That's where you got to get a little closer.
Yeah, that's why I wanted the sheath a little bit closer, PK. You might have, you might get the angle also might help you deploy. So that's perfect. I think you got it. I think your cranial view opened it much better. Yeah.
It's unusual. Let's see now with the sheath closer. Let's see what he gets with this picture.
No, it's a complete.
Boy, it's completely not.
Yeah, I did.
I don't get that picture.
I think it's because it starches.
I think we're going to come back with the sheath a little bit.
Well, I think the stent just has to go in quite a bit.
And you'll just have to change your angle because this angle is not helping.
LAO 30/20 or something like that may.
I think that's pretty damn good, guys, but let's see.
I think that I like this one. I'm not sure in that view where the proximal end is.
I think the only view may be.
Hold
on, let me see this view.
That's probably the view. That's your view.
Let's see. Don't inject, Michelle. I got it.
Okay, sure.
Pistol, we're good.
Yeah, now we should be able to see it.
Yeah, you have to go in.
Go in quite a bit.
You have to go in.
I'm just a little.
Hey, PK, earlier we did see a view where we saw this. Maybe you can go back to zip through your
40 is too long.
I think the wire is also straightening it out, Chris.
Yeah.
That's what I think. I may be wrong in that because,
But you had a wire in it before.
Yeah.
Okay, let's see here. Let's go past all this.
That view is good.
This is LAO 34 cranial 11. But again, I think it's a little foreshortened.
No, but you have room to land it, so that's all. That's all you care about.
I don't want to compromise the innominate. That's what I'm worried about.
For sure.
That's what Chris is worried about, because we have a good proximal landing zone. So the idea would be.
Now remember, no, you had that IVUS. Go back one view.
One view before.
Go one view before. Back.
This view.
One more. Where you had the IVUS catheter. Remember that we saw that we were in the proximal subclavian artery on an IVUS. There.
So let's do this. Let Vishal. Okay, I have an idea here.
Yeah.
Vishal, we're going to inject through this catheter. So there's LAO34. Hold on. LAO34. Yeah, cranial level. We're there. So now, Vishal, you're going to go ahead and inject from above.
Right.
Okay. Let's see. Ready?
From the guide.
Yep.
Mm-hmm.
Mm-hmm.
Yeah, you have to go in.
Yeah.
Yeah.
We have to go in.
We
You have to go in.
So.
Yep. You agree,
You have
guys?
to go in.
Yes,
Yeah, you have to
absolutely.
definitely go in.
Yeah.
So now
And
inject
that
from
goes to
below,
the
and
tip of
that's
the
the
guide.
ostium. Well, the ostium is going to be, but we have plenty of room, so we can definitely.
Yeah, we have plenty of room. That's what I'm trying to say, PK. You can go in.
Go in.
Yep. Make sure your wire's in the arm so that you're not
Yep,
prolapsing.
that's good right there. Okay, now let's take this.
That
forward.
looks like a good spot.
And you can be around the
Right
band.
there, right
there.
And
Yeah.
that's a
That
big
looks like a great spot.
subclavian, nice landing zone.
Yeah, that looks like a great spot.
Now we're all happy. Are you
Right
happy?
now, everybody's
much
happy.
Yeah, the only thing is, PK, when you start deploying it, it might go forward a little bit because of the torch. You might want to watch that.
Or even
Well,
pull back.
And even pull back a hair when you're
Yep,
deploying
I'm
it, you
gonna
know?
do a little quick
Keep
roadmap
backward
here
tension
for
on it.
Vishal. Oh, I definitely appreciate what you guys are saying, because these are the points that you got to remember while you're doing these lesions. I mean, it's all easy. You know, you set everything up, and then the
Yeah, it's perfect.
move.
Very
So,
good.
go
I
ahead,
like it.
Vishal. So Vishal's going
Even if it goes in a touch, it's still okay. We are still nailing it.
But PK,
You
you're
want to fix the
absolutely
sheet? I don't
correct.
want to-
We're spending 10 minutes getting this ready because it's a very important 10 minutes.
Yeah.
You
So
know,
what I'm going to do is, as Vishal starts, I'm just going to go ahead and give him a little puff it out for him, you know, without, you know, hopefully that's perfect. See?
That's good.
Like that.
I like that. Puff it out.
So I think we're pretty much at the ostium here, you know,
You're
maybe
perfect.
a little. Yeah, so I'm just going to keep it.
Vishal, no pressure. Vishal, no pressure, okay?
Vishal's doing
Okay.
it.
Vishal, make sure you don't miss it.
No, you got it right there.
You got it right there.
Everybody
Come on,
can see,
Vishal.
so
You can do it,
stand
Vishal.
right there.
Yeah, you can do it. Come
see
on.
it.
All right.
I see it.
So
That's
Look
looking
at
good.
this. Go ahead.
as you can imagine, these two guys were, you know, pretty much very close during not only training, and Vishal was just out when Karthik started. So a lot of ribbon going on here. You know, poor Vishal, you know.
Vishal, make sure that you put backward tension. Don't miss it.
Hey, wait,
Don't
listen,
miss it.
I
Maybe
see
I'll-
the look in his eye right now, guys. It's the advertising.
There you go.
There you go. Yeah, Vishal.
Guys, can you show the hemodynamics?
Also, we operate on the same day.
Show the
Me and
hemodynamics
Vishal
of
operate on the
Chris.
same day.
Just
We'll
with
be very
stenting,
close.
With the stent. Yeah.
just with stenting,
Yes.
the hemodynamics are fine. So
Yes.
now
Yeah,
the
there you go.
question is,
Equalization of pressures.
equalization of pressures have occurred. So now the question is what we're going to do. Do we balloon this, post-balloon it? What do we do? So I'm just going to take different views, and then we'll decide. So first, Vishal's going to inject from the arm. The pressure volume is good. Let's just bleed back
Yeah.
to be
let's
super
do
careful.
Exactly. Hold
Give
on.
me a little bit of this thing.
As Voltaire says, great is the enemy of good.
Yes, I know.
No, it looks very good, but you have to post it.
We've got,
All
we've
this
got
other funny
branches.
stuff.
Because
Yeah.
nothing went through that.
You've got no gradient. It's
Exactly, yeah.
self-expanding.
So Chris, I'm just going to do this view here. Only question here, Chris, is that this is obviously a nitinol stent and it's open cell. So the idea here would be, okay, what are we doing, right? So here you've nailed the ostium. Obviously it's foreshortened a little bit, but clearly you've gotten the ostium. The idea here would be
RIMA is okay.
Now
Rima's good.
I personally would
Vert's
balloon
okay.
it because we
Yeah,
can IVUS it to make sure, but to me,
I think this
I would balloon it too, PK. I would balloon it too with a 9.0 or something. I would balloon it.
you know,
I
the
don't-
only idea is, Chris, what do you think here?
I got to say, you've got a zero gradient. It looks pretty darn good. There's consequences here if you do anything, because you're pretty darn close to the RIMA, which is important in the right vert, which has beautiful flow in it.
Yeah.
I think we would just leave it.
I'm a perfectionist at heart, but this is one time this perfectionist may say, you know, there's 5 things telling you you're okay.
Yeah.
So you can see we did not cover the ostium, which is wonderful.
Yep.
We landed in the proximal landing zone, which is wonderful right there. And yeah, Chris is right. I kind of agree. I want to treat.
You know what I want to do?
I want to treat it as a carotid here. Yeah. And a carotid, we would never post-dilate this. You've got important vessels. I think we're done.
And think of your balloon options. The shortest balloon you're going to have is a 20. By definition, by not covering the ostium, you're going to be balloon across the RIMA and the right vert.
Agreed.
I mean, brother, this looks beautiful.
Yeah.
I don't know how you make things look more beautiful than beautiful.
I know.
Yeah. But Chris, just a quick question to you. Just taking the wire out here just to make sure we're not getting in any issues. Chris, follow up on this gentleman, right? So I'm curious what you do. Obviously, there's no guidelines, and I always learn from our friends who are doing a lot of these cases. So one is, just a couple of questions, and then I guess we'll chime in on what we may do. One is antiplatelet therapy, duration and choice. Second would be imaging surveillance. And third would be, would you add an antithrombotic?
Yeah, boy, great question. So, all right. So first of all, I'll take the easy one. And I'll give it the hard one to these guys. So this guy has coronary drug-eluting stent you just put in. He's got stents all over his body, and he has a vascular path with Takayasu's. He gets dual antiplatelet therapy for life from Chris. That's baby aspirin. Effient may be easier because he's relatively young and it's once a day, but he's already on Brilinta. If he can afford that and take it and is not short of breath, he gets strong dual antiplatelet therapy. Then the question is, do you add rivaroxaban, either one of you? For me, it's a cost issue.
Yeah.
I don't force it in Tennessee.
I mean, he's on Brilinta, so technically, I don't know. Xarelto is an option for him right now, because if you want to add Xarelto, then you have to change it to You can put Brilinta and Xarelto, but a little too strong for him. I don't think it's necessary.
Yeah, I think for this guy,
I think aspirin and Brilinta should be fine.
He may actually have re-intervention from a coronary perspective. Assuming he doesn't get a class 1 indication for anticoagulation, will probably be on at least 1 year until his subsequent intervention of DAP. The question is lifelong. That's a very interesting point.
PK, would you IVUS? Would you IVUS it?
I'm just concerned. I agree with Chris here. I think it's very important what he said. And also what Raman, who's our resident English major, quoted. I think it's important. The idea here is also like I suggested. It's a question of we don't want to go back in. We're not going to have Chris Metzger with us all the time. And so the question is, I want to give him the most durable therapy. But the problem is we are lacking data here, right? So therefore, I think with that, and physiologically, it's a physiologic disease.
Correct.
We have now corrected the physiology. I'm going to leave him alone. But that's why I'm a little, if I do IVUS, Karthik, I think all of us in the panel would agree, we're going to end up probably doing some stenting here. So our RIMA flow is fantastic. The vert flow is great. I think at this stage, just leave it alone with that, and that's why I'm not IVUSing.
For some maybe it's like a little bit of a provocative. If you do want to really think about purely physiologic, right? So this guy had anterior ischemia because of RIMA disease. One thing you could do if you really are bent on doing some form of testing here, you could do an IFR from the groin to see if I'd
rather just do a stress test, Roman. I mean, we had documented anterior ischemia.
If you want to do something now, yeah. I think we're absolutely done. I think we should go for closure devices.
All right. So back to your initial question, PK, what will your surveillance? I mean, obviously a carotid duplex, you want to make sure there's integrated flow. There's so much, you're going to follow that right carotid like an eagle hawk.
I would probably pull the guide back, Vishal. Yeah.
Yeah, he is.
I'm taking
But Chris, I agree. Yep, take it out. Yep. I agree with you. I think we're gonna go do a carotid duplex before he goes. We're gonna do obviously a subclavian, look at the subclavian, and then what we're gonna do is we're gonna get room to see him, weigh in on everything, make sure that he's on the proper medication for his Takayasu's, which he is, but we want to make sure whether things have changed. And the idea now is just survey him. I'd probably be a little bit more aggressive, maybe every 3 months for the first year, Chris, and then after that, I'd probably leave him since there's so much vascular territory at risk on this stent that we've done.
Now, he's not a smoker? Please tell me that.
No.
Because, I mean, he's got so many disease processes throughout. By the way, I've never seen an LDL 22, so nice work there between Repatha and Crestor and Imuran. That's a pretty good LDL.
So question, Chris, this came up when we all discussed this with the issue of, do you think this stent may fracture the way it is? Hold it right there for me.
And that's a great question, and that is one of your surveillance things that you might want to do. A simple chest X-ray would probably tell you that, but once in a while, a CT angiogram, you're going to be following that right carotid and innominate very closely anyhow because it's so important.
PK, one other way to do it is if you lift his arm. I mean, sometimes if it's more subclavian or axillary disease, you can lift their arm and see the velocities in the Doppler and see if it's causing any compression of the clavicular compression. But I don't think that's the position of this stent. I think it's a little more proximal than that. But I think it's not a bad idea to lift the patient's arm and see if the patient is awake.
Yes, sir.
Yeah.
It's not a bad idea to do that. Take a picture after you lift the arm.
But you bring up the interesting issue of stent fracture. Actually, a nitinol stent may be better for that here.
Yeah,
we've seen stent fractures in the innominate and in the right subclavian artery in this territory. So I think the nitinol is actually going to have less issues of stent fractures.
Agreed.
And they won't be a transverse fracture.
It's more flexible and I think it's
probably going to the carotid more.
Okay, so I just wanted to show that we missed the ostium, which we did.
You did.
So now we're excellent. So I'm pretty happy with this, Chris. If it's all right with you and our team, we're going to pull out here and we're going to let you guys close up, get you on your way. Before I say anything, I just want to thank, Dr. Metzger. I know we call him Chris. Like I've told you, I've known him for almost 15 to 17 years, and it's actually a phenomenal privilege to me that he took his time and came to our lab here at Sinai. I mean, he's an incredible operator, and you heard by the comments for all of you at home. I told him we get approximately around 5,000 views a month of our cases worldwide, and I know this is going to be incredible with Dr. Metzger. So I really appreciate Chris that you took the time from your busy practice, family, et cetera, to come here, and really without you, I think this case would not have gone as well as it did. So thank you very much.
That's very kind, PK. It was a pleasure to be here. I'm surrounded by Mount Sinai brilliance. I mean, on both sides of me, watching every part, and within the
pleasure is all ours.
Listen, this has been an honor for all of us. A great job by everybody there. Thank you. This is a tough case, and you taught us and taught a lot of people some of the important parts. So great job, and thank you. It was great to be here and be a part of it. An honor. Thank you all.
Thanks again, Chris, and thanks Vishal and the team here, and thanks Raman and Karthik. I'll see you guys in a few minutes. Thank you, guys.
All right, guys.
Thanks, guys.
Bye-bye.
Dr. Metzger, Dr. Guja, thank you very much for joining us. Thanks a lot, Dr. Guja, for that great case. And we look forward to joining you, having you join us once again on Wednesday, April 26th for our next live peripheral broadcast from Mount Sinai. Thank you very much. Have a great day.
Great.